Well, the MAP conference, in fact, is trying to address one of the most important scientific questions that the cancer community is facing, which is how do we really integrate in daily practice the wealth of information that comes from the analysis of a tumor sample. There is many structural DNA changes that happen in a tumor, and we need to make sense of the signal we can get from that analysis and integrate that in daily cancer care, diagnosis, prognosis, and therapeutic decision. I believe so, and this is the case in many solid tumor types. Rare cancers like the gastrointestinal stromal tumors, GIST, frequent cancers such as breast cancer, colorectal cancer, and lung cancer. Let me give you an illustration in the setting of thoracic malignancies, non-small cell lung cancer, which I know better. In that setting, it is absolutely key to identify some of the frequent oncogenic drivers, because the patients who have an oncogenic driver, EGFR mutation, ALK translocation, or ROS translocation, have a better intrinsic prognosis. Median survivals are 36 months, while the standard survival for metastatic non-small cell lung cancer is 12 months. So you see there is a 1 to 3 length of survival, and the therapies are not going to be the same. In the presence of an oncogenic driver, we will be using a variety of kinase inhibitors to guide the therapy, which might not be the case in the setting of patients who do not have an oncogenic driver. This is one very practical example. So today, standard of care in lung cancer makes mandatory the analysis of some oncogenic drivers that represent 15 to 20% of our patients. Much higher percentage in Asia, for instance, where these alterations represent up to 40% of the patients. Well, you know, there are different approaches. I would say that two ways of looking at the problem. There are technologies that try to make the most of a tissue sample, and these are mostly focusing either on analyzing structural DNA changes on the tumor cells or analyzing the tumor microenvironment. That's on one side. On the other side, there are all the approaches that will not be based on the tumor tissue, but based on blood, and that's what some people refer to as liquid biopsies. So we try to characterize the cancer environment in the blood. And in the blood, not only you can analyze mutations, but technology probably is allowing us now also to look for some translocations. On top of that, we know that in the blood we have circulating tumor cells. We do have also exosomes who carry inside their vesicles DNA, RNA, and proteins. All these issues. Well, it is interesting to realize that precision medicine and immune oncology are not two divergent paths. There is some area of synergy and potential overlap. And in fact, there are recent publications suggesting that the mutational tumor load in a given sample, meaning how many mutations you have per megabase, might predict for the efficacy of some immune checkpoint inhibitors. So the higher the mutational load, the higher the efficacy of the PD-1 or PD-L1 antibodies. And this has been demonstrated in melanoma, in lung cancer, and in colorectal cancer with mismatch repair deficiencies. So this is a very interesting topic where two different scientific themes, immune oncology and precision medicine, instead of being perceived as antinomic, really have an overlap, and there is a common theme that might help us better understand how the structural DNA changes can predict for the efficacy of immune checkpoint blockade.